Good evening. For those of you who are watching our session live, I want to welcome you to this week's happy hour. If you have, as always, any questions, you can send them to education@sagesdx.com. I'll be watching the chat during this live session. For those of you who are watching the video recording, again, you can use the same email, education@sagesdx.com, or you can email me directly at tdavis@sagesdx.com. We're always looking for suggestions of topics that you would like covered, subject to address. So if anybody has any suggestions or feedback, we would appreciate that as well. This week, it's my privilege to introduce one of my friends and colleagues, Dr. Liliana Rincon. Liliana is board certified in anatomic pathology and clinical pathology. Originally from Columbia, she did her training in pathology at the University of Texas Medical Branch in Galveston, followed by a surgical pathology fellowship in Houston. She then completed a Dermpath fellowship back in Galveston at UTMB, where she subsequently served as a faculty member. She joined Sagis Diagnostics this past summer, but still holds the position of assistant clinical professor of pathology at UTMB, and there she regularly teaches dermatology and pathology residents. All to say, she's a seasoned dermatopathologist with a lot of experience teaching, and I know you'll enjoy the discussion of her cases. So without any further hesitation, I'll go ahead and turn the floor over to Liliana. Liliana?
Thank you, Dr. Davis, for the wonderful introduction. Today I will be presenting some interesting cases that I would like to share with you all. I hope you learned. And if you have any questions, don't hesitate to contact me through my email. That is lrincon@sagesdx.com. Again, lrincon@sagesdx.com. Okay, so let's start now with the first case. So in the first case, we have a shape biopsy of palisaded and encapsulated neuroma. So you can see this is a shape biopsy. The epidermis looks normal, and this is there is this spindle cell proliferation in the dermis, where you can see these fascicles that are separated by this clefting artifact. And also you can see that the cells have these spindly, dark nuclei, and in between the fascicles, you can find sometimes mast cells, like one here. So these are the characteristic features of palisaded and encapsulated neuroma. So remember, fascicles with the clefting artifact, and it's not encapsulated, no palisaded, because you don't see a real capsule, you see like a well circumscribed lesion, and it's somewhat palisaded because you can see some nuclei have like a palisading kind of feature, like a schwannoma. But the difference with the schwannoma is that the palisaded encapsulated neuroma is more superficial in the dermis, while the schwannomas are deeper, and normally in the schwannoma you don't get this clefting artifact. Okay, let's go to the second case. The second case is a mixed tumor. And let's start. So in this case, you can see there is a well-circumscribed tumor that has three characteristics. So the first is this epithelial component that you see here, with this ductal component, and surrounded by all these myxoid matrix. So those are the three characteristic features of mixed tumor of achondroic. So first is a well-circumscribed tumor. You have this epithelial component with the ducts and the mixed mesenchyma around the epithelial component. This chondroic, this mixed tumor, is the same as a pleomorphic adenoma of the salivary gland, and in the skin is called mixed tumor chondroid syringoma. Okay, let's go now to the third case. The third case is one of those invisible dermatoses that Dr. Bender talked to you about last week. So this is a punch biopsy from the foot of a patient. And then you can see that you have these thick stratum corneum with kind of normal epidermis, and then you have the dermis underneath, but you really don't see anything that you can pinpoint to give a diagnosis at this moment. Maybe in the stratum corneum, you have this kind of clefting or separation, and you can see some kind of stuff in between the stratum corneum. And then you do a PAS, and the PAS will highlight the hypha that are in the stratum corneum. As you can see here, this 9 hypha, and this is consistent with dermatophytosis otinia. So this is one of the invisible dermatoses where you don't really see anything in the H&E, but when you do the PAS stain, so then you get all these hypha in the stratum corneum. Okay, let's go to our fifth case. So our fifth case is a shape biopsy of a trichilemmoma. So the trichilemmoma, so you see these kind of bulbs that come down into the dermis from the epidermis. And then in these bulbs, you see these clear cells that are full of glycogen. And then in the periphery of these epithelial bulbs, you see this palisaded and a kind of a thickened basement membrane. Something important for this tumor is that multiple trichilemmomas are associated with Cowden syndrome, and you can confirm the diagnosis and differentiate the diagnosis from a BCC with the CD34 that will stain really beautiful the epithelial cells that are full of these glycogen. So here you can see how the CD34, that is a cytoplasmic staining, will stain all the cells that are full of glycogen in the trichilemmoma. And remember that it's associated with Cowden syndrome. Okay, let's go now to our seventh case. Our seventh case, as you can see here, is a biopsy of a well-circumscribed dermal tumor, and is consistent with a giant cell tumor of the tendon sheath. The location first is very important. It's normally located on the hands, fingers of from the interphalangeal joint. And this is a well-circumscribed tumor that is in the dermis, and normally you have these this grandson, where you can see that is respected between the epidermis and the tumor. Then when you go higher magnification in the tumor, you can see that you have these histiocytes that are like plump histiocytes. And in between the histiocytes, you have this collagen. And what is very characteristic is these multinucleated osteoclastic like cells that are all around the tumor. You can have some mitosis in this tumor, but if you have a well-circumscribed tumor full of fibroblast, full of giant cells with these histiocytes that you can confirm with CD68, immune stain that give you a diagnosis for a giant cell tumor of the tendon sheath. Okay, let's go to our eighth case. So our eighth case is punch biopsy from the lip. And this punch biopsy, if it's from the lip, then you can see the minor salivary gland that is normal. It has all the characteristic features of a normal minor salivary gland with all the lobules and ductules in the salivary gland is well circumscribed. You don't see any lesion infiltrating or going out of the salivary muscle of the salivary gland. But when you start scanning the tissue, you'll see these well circumscribed granulomas that where you can see all these giant cells with multinucleated giant cells surrounding this foreign type material that you can also see here underneath. And this foreign material is a bluish and has a characteristic features of hyaluronic acid. And this was confirmed with the clinician that the patient had recently had injections of hyaluronic acid on her lips. So this is a really nice case. It's not something that we see really often, but I thought it was worth it to share with you because it's such a beautiful case. Okay, let's go to our 9th case. This is a very classical case in Dermpath. So this is a shape biopsy of a Molluscum contagiosum. So the Molluscum contagiosum, you can see, and the characteristic features is a really pretty tumor where you can see that you have this scalloping of the epidermis with these intracytoplasmic inclusions that are called the Henderson-Peterson bodies or Molluscum contagiosum bodies that are very characteristic. So this is a very characteristic lesion for Molluscum contagiosum, and it's a very characteristic lesion for Dermpath. Okay, now let's go to our 10th case. So our 10th case is from the upper eyelid, and it's a shape biopsy. And the diagnosis is Xanthelasma. So in a Xanthelasma, you can see that the epidermis looks normal. But then when you see the dermis, you see that there is this infiltrate of these clear cells or foamy histiocytes. And these foamy histiocytes are full of lipid, and they have some sprinkled lymphocytes in between. So this is very characteristic for a Xanthelasma. Remember that half of the patient that have a Xanthelasma have some hyperlipidemias. So remember these foamy histiocytes full of lipid with these sprinkled lymphocytes from the islets is very characteristic for Xanthelasma. So let's go to our 11th case. So our 11th case, we have a Glomus tumor. So in the Glomus tumor, you see this, so first the epidermis is normal, and then you have this dermal proliferation of these very well defined or very well monotonous cells surrounding these delicate vessels. And these cells are really characteristic because you can see that the nuclei is very round, is dark, and they have a really eosinophilic cytoplasm, and they're called the string of pearls, black pearls, because they're dark and they're very monotonous. And this is very characteristic of a Glomus tumor. Remember that these lesions are painful. Okay. So now let's go to our 12th case. So our 12th case is also a very characteristic case in Dermpath. So here you can see from lower magnification, really heavy infiltrate in the dermis. And when you go high power, you're gonna start from the stratum corneum, and you see these kind of bodies in the stratum corneum. And when you go higher magnification, you can see that they're mites. And this is very, very nice. And then when you go into dermis, you see this lymphocytic, mostly perivascular infiltrate with lots and lots of eosinophils that you can see here. And this is very important because the differential diagnosis for this type of infiltrate, where you have all these lymphocytic infiltrate around the vessels with numerous eosinophils. So the differential diagnoses are a drug eruption, an insect bite, or a hypersensitivity reaction. So this is very characteristic for scabies, where you have these beautiful mites in the stratum corneum. Okay, so now let's go to our next case. That is also a very nice dermatofibroma. It is a very nice dermatofibroma. So in a dermatofibroma, you see acanthosis of the epidermis with this hyperpigmentation of the basal layer. And then when you go into the dermis, you're gonna see this spindle cell proliferation in the dermis. Those spindle cells are delicate, and if you see the spindle cells are wrapping the collagen, so you see these globules of collagen being entrapped by these spindle cells, and this is very characteristic for a dermatofibroma. Sometimes in the middle of the lesion you see all the spindle cells, and sometimes you cannot see the entrapping collagen in the middle of the lesion, but if you look in the periphery, there is always entrapping collagen in the periphery, and it's very characteristic for a dermatofibroma. So let's go to our 14th case. So our 14th case, you have this, this is a clear cell acanthoma. The clear cell acanthoma, you have this acanthosis of the epidermis, and then in the epidermis, you have these clear cells that are really well circumscribed from the normal epidermis. So you can see here, like it's a line that divides the clear cells from the regular epidermal cells. And these cells are clear because they're deficient in phosphorylase, resulting in accumulation of glycogen. So this is important to remember for the boards. So this is a beautiful clear cell acanthoma. So let's go now to our 15th case. So our 15th case is viral cytopathic changes that were consistent with herpes zoster after the immunos, because to just make sure what type of viral or virus is producing the herpetic changes, you have to do immunohistochemistry, so VCV or HSV1 and 2. So in this case, it was positive for BCV, so it was consistent with herpes zoster. So in the herpes or cytopathic changes for this viral infection, you have what is characteristic that we call the 3 M's. The 3 M's will be multinucleation, margination, and molding. So then you have to find the nuclei. And for example, in this large cell, you can see there are 3 nuclei, so multinucleation. There is margination because you see that some of the chromatin or the chromatin in the nuclei is going to the periphery and is darkening the periphery. So that's margination. And molding because you see that one nuclei tried to mold to the other nuclei. So those are the 3 M's for viral cytopathic changes. So margination, multinucleation, and molding. Okay, so let's go now to our next case, 16. So our next case is a Pilomatricoma. So you can see in the Pilomatricoma, there is a well circumscribed lesion in the dermis. And the Pilomatricoma has 3 characteristics too as the viral cytopathic changes. So you see blue cells, then you see the ghost cells, and then you see calcifications and sometimes multinucleated cells. So these blue cells are coming from the matrical differentiation that then differentiate in these ghost cells where you can see like an empty kind of nuclei, and that's why they're called ghost cells. And then you see the calcifications and the multinucleated giant cells. So this is a very nice example of a Pilomatricoma. And remember that multiple pilomatricomas are seen in myotonic dystrophy. Okay, so our next case is an sclerotic fibroma. So this is a shape biopsy, and you can see that there is a dermal proliferation of these collagen bundles that have this clefting artifact between them, and the few nuclei that you see in between are very delicate. And the clefting artifact gives you an impression of plywood, and that's why it's called plywood. The sclerosis in the dermis, you can see that it has this clefting artifact, and there is what is called like a plywood appearance. So this is a sclerotic fibroma, and remember that as well as a trichilemmoma, multiple sclerotic fibromas are seen in Cowden syndrome. Okay, our next and last case is Angiosarcoma. So here you can see that it's an ulcer first because the epidermis is missing here, and you see necrosis and all these neutrophils and a lot of red blood cells that have been extravasated. And then when you go high power into the lesion, you see that there's some pleomorphic cells, very dark cells in the dermis. So you can see in all the sections you have these dark pleomorphic cells in the dermis. And when you go even higher magnification, you see that these dark pleomorphic cells have all the malignant features. So it has prominent nucleoli. There are multiple mitosis, like this one throughout the cells. And they're very pleomorphic, different from one to each other. And they just look very malignant. Plus the necrosis and the ulceration just points out that it's something malignant. So after doing immunohistochemistry, we found out that the tumor was positive for all the vascular markers. So the first vascular marker is ERG. So the tumor was positive for ERG. The second vascular tumor that is a little bit more specific than ERG is C34, and the tumor was also positive for C34. And lastly, the most specific marker for vascular lesion is C31, and the tumor was positive for C31. So this poorly differentiated tumor was consistent with an angiosarcoma. Okay, this was all the cases I had for you. I hope you enjoyed the presentation, and please don't hesitate if you have any questions. Just email me to my email that is lrincon@sagisdiagnosis.com. Thank you, and I hope you have a nice day. Bye-bye.
Thanks, Liliana. Really do appreciate that. And again, if you have any questions, please, or suggestions for future sessions, please reach out and email me directly, tdavis@sagisdx.com or education@sagisdx.com. Hope everybody has a great evening. Thank you.